Should I see next speaker?
Yes, now we are having the third topic, that is the severe hypoglycemia and cardiovascular complications and a complex relationship. We are having the very good speaker from Germany, that is the Ebehard Standl. Dr. Standl is a professor of medicine and specializes in the field of diabetes and endocrinology and angiology at the Munich Diabetes Research Center. Dr. Standl is principally areas of the research including the diabetology, degeneration of the insulin, and epidemiology of the cardiovascular disease and complications. Previously, Dr. Standl was director of the Department of Endocrinology and Diabetology in Metabolism at the Academic Hospital of Munich. He also worked as a world-renowned Joslin Diabetes Center. Dr. Standl served as a member of the Scientific Committee in Innovation Corporation. Since May 2014, Dr. Standl has served as a president of Germany Diabetes Union and International Diabetic Federation of the Europe, as well as the vice president of the International Diabetic Federation of European Society, European Association of the Study of the Diabetes, EASD. Now I am inviting, and before that we are having the poll question, does the presentation of the hypoglycemia varies?
Does the presentation of hypoglycemia varies in elderly patients? Dr. Stan, you share your slides?
Yes.
Yes. Now you can start, sir.
Okay. The slides are on here. So does this look right to you? Can you hear me?
Yeah,
yes,
it
sir.
is clear. You start
You
the
go
slide.
full screen?
I have to go to full mode probably.
Yes, sir.
Okay, so thank you very much for the real great privilege and honor to lecture at this very important meeting. And of course, it's fascinating what you can do in these times of Corona. You still can be in contact with all the peers all around the world. So thank you very much for this opportunity. As you see, I will talk about severe hypoglycemia and cardiovascular events, a complex relationship. And I should stress it's largely on severe hypoglycemia. I come to the definition in a minute. And it's also largely in type 2 diabetes as assessed in cardiovascular outcome trials. And this also is reflected in my disclosures. You may see I have held a leadership function in a number of trials where we analyzed actually severe hypoglycemia is an adjudicated event. So it's a very robust data situation in relation to all the cardiovascular events, again, adjudicated. So this, I think, this was our reasoning that really gives you a robust basis for looking into that. And as you may also see, perhaps my talk is something like my personal journey along the winding roads, analyzing and looking into the relationship of severe hypoglycemia and cardiovascular events. Now, definitions, classification of hypoglycemia, the recent consensus is put forward also by the ADA. And here we are talking about level 3 a severe event characterized by altered mental and physical status requiring third-party assistance for treatment of hypoglycemia. Of course, this audience knows there are less severe forms of hypoglycemia as related to neuroendocrine responses related to neuroglycopenic symptoms. But as mentioned, my talk is largely on level 3. And of course, this is a very unpleasant situation. I think everyone agrees we want really to avoid and prevent level 3 hypoglycemia. It can be rather dangerous. We had a question earlier on the elderly patients. Elderly patients may have falls, may have injuries, really accident, even fatal accident at home, tripping down the stairs, etc. So very, very clearly, there's a very strong mandate to prevent hypoglycemia. This is not the argument. And then there is this potential cardiac harm related to severe hypoglycemia. Interesting data, type 1 and type 2 diabetes. And as you may see, the prolongation of the QTc interval in the ECG, which is really a risk for severe arrhythmias and even sudden cardiac death. In severe hypoglycemia, it's present more than 50%. Hypokalemia, low serum potassium, is also very, very frequent. Again, being associated with arrhythmias, and also the sympathetic overdrive can lead to hypertensive critical situation, especially in type 2 diabetes. So there's a huge background why severe hypoglycemia may be harmful, especially in relation to cardiovascular outcomes. And just one example, at this we had a patient with continuous glucose monitoring and also an Holter ECG, and you see any time when he reached the thresholds of hypoglycemia, there were arrhythmias. So this is a summary as put forward by the International Hypoglycemia Study Group last year in Lancet Diabetes Endocrinology, drawing the picture hypoglycemia clearly related to the sympatoadrenal response and epinephrine overdrive. I showed you some example of that. On the left side, the activation of platelets and other factors really fostering acute thrombosis and complications. Out of that, inflammatory responses, and not the least also endothelial dysfunction. It's no question that some patients really may die in association with severe hypoglycemia, but what about the more longer term cardiovascular events once patients really are out of severe hypoglycemia? And this is how we got really involved in that in the TACOS trial, where we, of course, evaluated sitagliptin, some 14,000 people with pre-existing disease. And here you look at the association between severe hypoglycemic events, more than 300 adjudicated, and subsequent risk of cardiovascular events and death. Now let's look at the top panel here, unadjusted, 4-point MACE, you know what that means, fatal, non-fatal MI, stroke, cardiovascular death, and in TACOS it was also hospitalization for unstable angina. Yes, significant association also with 3-point MACE, all-cause death, cardiovascular death, nothing for MI, hospitalization for stroke, and hospitalization for heart failure. And of course you need to adjust, and everyone had done this. And there are about 10 different publications very similar to ours from other cardiovascular outcome trials. And if you do the typical demographic adjustment for age, sex, race, smoking, it doesn't change the association. However, if you adjust for all significant predictors of MACE, of the 3-point MACE outcome, and I come to the list of factors which determined MACE in TACOS, you suddenly realize that the 4-point MACE, 3-point MACE was non-significantly associated, alluding to the fact that probably there are factors in the background associated both with MACE outcomes and with severe hypoglycemia. So this can be common confounders. And what could be the list? First of all, we determined the predictors of the 3-point MACE as covariate selected by modeling here. And you see that this is the full list. However, those with the red squares also predicted severe hypoglycemia in TACOS. And this is age, sex, ethnicity, insulin therapy, low estimated GFR, and diabetes duration. So a number of factors predicting severe hypoglycemia are also predicting the MACE outcomes. Now, there has been a very nice editorial on this possible relationships, severe hypoglycemia related to higher risk of mortality and MACE. And of course, we are talking, I don't have the cursor, between severe hypoglycemia and mortality. Now, as already alluded to, there may be common confounders, especially impaired kidney function. The lower the estimated GFR, the more of both of that. And of course, there are also non-fatal MACE events. And if one would look at non-fatal MACE and afterwards occurring severe hypoglycemia, so the reverse of this would mean reverse causation or common confounders. Now, what happened in TACOS? Yes, we described this increased risk of severe hypoglycemic events before and after cardiovascular outcomes in TACOS, suggesting a common phenotype at risk, type 2 diabetes, a frail phenotype, vulnerable really for both of the complications, severe hypos and cardiovascular events. Now, look what happened if you look at the other way around, the association of non-fatal MACE or even heart failure outcomes with the risk of subsequent, so afterwards, severe hypoglycemic events. You see rather striking associations unadjusted for, after non-fatal event or hospitalization for unstable angina, non-fatal event, non-fatal MI, hospitalization for unstable angina, no association, stroke, and particularly, and this is really very interesting, and this was novel at the time, the sequence hospitalization for heart failure and later on occurring severe hypoglycemia. Now, if you do demographic adjustment, it doesn't change. And if you do adjust for all MACE predictors, it stays significant, in particular also for hospitalization of heart failure, meaning there must be something in the background related to the cardiac injury which renders people more vulnerable for severe hypoglycemia. And so we argued a common multimorbid frail phenotype vulnerable to both severe hypoglycemic events and MACE and also heart failure events. Now, this was one study, or now before that, we also looked in the association with baseline hemoglobin A1C. We have defined categories of A1C, as you may see on top here, A1C 6.5, and so on and so forth. But as you can also see, the lower A1C was not associated with the risk of severe hypoglycemia. Actually, the risk was higher at those with higher A1C categories at baseline. And also when you updated all the hemoglobin A1C values measured, there is no association. So from there, we feel severe hypoglycemia neither associated with baseline nor with the updated hemoglobin A1C. Now, of course, one study, you need to confirm and validate this. And we had the opportunity to look in the Excel trial, again, at this Association of Severe Hypos and MACE heart failure outcomes. As you know, close to 15,000 patients, 466 actually had severe hypoglycemia. Now, this is the trial with the largest number of severe hypoglycemia in those trials in type 2 diabetes, and 116, so around 1/4 of those with severe hypos actually had also cardiovascular events again, so it's a very robust database, and actually 66 had CV event after severe hypo, and 50 had a severe hypo after a CV event. Now it was interesting, we had 4 patients who had on the same day the severe hypo and the cardiovascular event. And this is why I really think it's a very complex association. 2 of them never had any other event, neither cardiovascular, any other severe hypoglycemia. So they stayed in the trial until the end of the trial. And one died next day on a myocardial infarction, so this would be cardiovascular, and the other one on a second day from a non-cardiovascular thing. So it's a very complex situation. Now, how does this emerging phenotype look at dual risk for severe hypos and CV events? And we assessed this in the Excel trial. It's age, it is duration of diabetes, very important. It is a prior cardiovascular event. Almost anybody had a prior cardiovascular event who also had severe hypoglycemia. And here we measured also the Charlson Comorbidity Index, which really gives you a prediction over the mortality over the next 10 years in those who had neither severe hypo and CV event. They had a Charlson of 5. Now that means despite the age of 62, their likelihood to die within the next 10 years is around 22%. So these are sick people without question. However, those at dual risk had a much higher Charlson, 7 or 8. That means they have no chance whatsoever to survive the next 10 years, just based on this comorbidity index. And I think it's really the key aspect in this association, the very high comorbidity. And just the line below A1C, you see there was no indication of low A1C being a driver for that. And I'm sorry, I can't really see on the side here. The point I still would like to make is many of them, 80%, were on insulin and also on a higher dose per kilogram body weight. Now, this clearly gives a clue what needs to be done in those patients, revisit insulin therapy. But the message is dual risk of severe hypo and CVD event most often are a matter of comorbidities, not of A1C. So those who use of agent with higher potential of hypoglycemia, of course, need to be minimized. Now, what were really the findings? Severe hypos after non-fatal MACE and heart failure events, very significant with the association with non-fatal MI and stroke, and also in particular with hospitalization for heart failure, a 4-fold increase, but very strong, very robust if you adjust for demographics, which didn't change if you adjusted for all the predictors of MACE. So this seems to be independent. And this then is the other way around, first severe hypo and then MACE heart failure outcomes. Again, adjustment for clinical factors, it's still associated with MACE, particular all-cause death. This has a very strong association, but the same thing in TECOS. If you adjust for all the predictors of MACE, the association with MACE becomes non-significant, meaning it are the background factors operating and really linking this association. And all-cause death state. Interestingly, also down there at the bottom, first severe hypo and later on hospitalization for heart failure also remained significant. So I think clearly it's a complex situation. Of course, of interest is the time dependence of, and we did the time-dependent hazard ratio plots, and this is for all-cause death. And as you see, closest to the severe hypo, all-cause death is up 5-fold compared to others, and stays up for a long time, up to 1 year. And the interesting part, but the numbers become very, very low. It seems to increase again even 4 or 5 years after. Now that clearly does not really allude to causative effects. It more points to surrogates in the background which are responsible for all-cause mortality. Now, interestingly, for the MACE events, both ways, the association remained twofold elevated, but no time dependence was really demonstrable for the MACE outcomes. Now, what have other people described? And the landmark study in this regard is the ADVANCE trial, now published 10 years ago. They looked at severe hypos with other risk. And as you see, within the first year of the severe hypos, they described death from any cause was really the major thing. Just what I showed you closest to the event, all-cause death is really up, and it stays up for a very long time, like we saw in the Excel trial. Now, cardiovascular death is actually minimal in this association, so was microvascular event. So it's largely in the ADVANCE. The significant thing is all-cause death. They actually described, they had also some 50 cases where they had severe hypos after an event, but they didn't really look into this in detail. So they may have missed really to have a chance to describe this bidirectional association. Another very interesting recent study is in the EMPA-REG outcome. And they looked on the upper panel for 3-point MACE. And as you see, with a very wide definition of symptomatic hypos, so it's not just severe hypos. And like we did not find an association with the 3-point MACE nor with cardiovascular death. But interestingly, they described also this hospitalization for heart failure association. So it's confirmatory what we found both in TECOS and Excel. And then they ask whether the primary outcome, and of course, EPIREC outcome was the breakthrough study showing a reduction of 3-point MACE with empagliflozin of cardiovascular death and also hospitalization for heart failure. And the question addressed here is, did it make any difference whether the preceding hypos as defined? And the answer is no. EMPA-REG effect was unchanged. So hypos as non-severe hypos largely did not really impact on the result here. Another important piece of evidence comes from Origin, an insulin study. And they actually had a large group of non-severe events also adjudicated in that trial. And as you can see, the association adjusted with factors like we did, showed non-severe hypoglycemia was not associated with the listed cardiovascular outcomes, whereas severe hypos demonstrated the same thing, around 70% increase. And they also went on and described it was more associated actually with sulfonylureas as compared to insulin. To tell you, neither in Excel nor in TECOS, we looked for sulfonylureas. We couldn't find any impact on this association. So how much can severe hypoglycemia contribute to the outcomes in outcome studies? And I showed you for the EMPERAC outcome where empagliflozin did not contribute, here is liraglutide, another breakthrough study called LEADER. And as you see here, there is a breakdown for patients with severe hypoglycemia, without severe hypoglycemia, but the differences in the MACE events are minimal. There are 14, and the hazard ratio stays the same. So there is very little potential that the occurrence of severe hypoglycemia may have contributed to the positive outcome in LEADER. And finally, also very telling recent publication is Carolina, where they actually randomized glimepiride versus linagliptide, really intentionally trying to make a big difference in the occurrence of hypoglycemia. You see the definition at the bottom, moderate or severe hypos. So it's a broader definition. It's not just severe hypos you're looking at, but of course, not unexpected. There was more or less a tenfold difference in moderate to severe hypos. Now, as you also know, there was no impact on the primary outcome results. So this was also an unexpected thing that, you know, the lines are superimposable for MACE, all-cause mortality, cardiovascular death, non-cardiovascular death, despite the very striking difference in hypoglycemia. So what are really the implications and the strategy to avoid severe hypos? And of course, avoidance prevention of severe hypos, in particular in more elderly people with all these really very risky consequences of severe hypos, it is a very important challenge. And we actually recognize the vulnerable patient phenotype, a dual risk for severe hypoglycemia and CVD events based on the described clinical characteristics, just a short repetition, older age, long duration of diabetes, a prior CV event, close to 98% had actually a prior CV event. They had very high comorbidity index. Now, of course, this is another score you need to do, but you can do it really with a very simple software. And it also includes, of course, cognitive function, liver disease, renal disease, cancer. So it's a list of 12 items for this Charlson Comorbidity Index. Heart failure, reduced estimated GFR, and most people are on a good number of cardiovascular drugs, and many are on insulin and at higher dose. Of course, if you find comorbidities, you need to treat them and reconsider the blood glucose lowering therapy, including the use and the dose of insulin. And in terms of the A1C target, and this is actually in line with most guidelines, the target 7 to 8%, so severe hypoglycemia was not necessarily a matter of A1C, but rather of comorbidities. And I think it's very important to keep in mind the ADA standards in the year 2020. We're actually in the center core of all this algorithm. They are the patient with the compelling need to minimize hypoglycemia, and just below there are the preferred drugs which you might consider for use in those patients. But not to forget, at the end, there are also some patients where you need to add in insulin, but that needs very careful consideration and also dosing. So, severe hypoglycemia and CV events revisited, findings and conclusions. Epidemiologic observation in cardiovascular outcome trials show significant relationship between severe hypos and CV events. Associations as such, however, are not really proof of a causal relationship. There are associations. Low rates of severe hypoglycemic events in cardiovascular outcome trials, and there's a very low potential to contribute to cardiovascular events like in LEADER, where I actually demonstrated this. However, a confirmed bidirectional relationship, suggests common confounders, and they need to be really considered, that severe hypoglycemia may contribute in some individuals, and this cannot be excluded, to sudden death, but the numbers actually, as we saw, were actually minimal. Adjusting for all predictors of MACE rendered the association with severe hypos non-significant. Clearly, the background confounders. And characteristics of patients at dual risk for severe hypo event suggest a distinct, multimorbid, frail patient phenotype requiring special therapeutic consideration, while they don't differ in terms of A1C. Non-severe hypos, and there's rather limited data, but I showed you, for instance, from Origin, but also the Carolina trial, apparently is not associated with cardiovascular events and mortality. So the final message, take home, dual risk of severe hypos and CVD events, most often a matter of comorbidities, not of A1C, so dose or use of agents with high potential of hypoglycemia should be minimized. And I thank you very much for this opportunity and for your attention.
Thank you very much, Dr. Stan. It was an extraordinary presentation from your side. I think so. I am asking for 3 speakers to come on the at least front face, because the session is open for the discussion. So I'll request Dr. Juliana, Dr. Raz, and Dr. Stan, please. And it was extraordinary presentation. Thank you so much.
Thank you very much. It was actually a Cody presentation where you always start with the controversies, trying to come to a consensus at the end. So I hope I really met this goal.
Yeah. Is the availability of Dr. Juliana and Dr. Raj is there?
Yeah, so Ebehard, very nice presentation. I
Yes.
think we also previously looked at our register, and then we also found that people who came in with severe hypoglycemia defined by hospitalizations, they have this kind of similar phenotype, very frail, and that is not so much related to the A1s, but rather the long disease duration, and then also the EGFR, and subsequently many of these also develop cardiovascular diseases. But in our situation, we also found that some of these people actually turned out to have cancer. And we just wonder whether, I think the message is rather than just adjusting the medications, these people probably need a reassessment, right? Maybe some of these people have been on a drug for a long time, and then, just repeating the prescriptions, but not really doing much of the assessment. And then they came in with this severe hypoglycemia. Maybe because there was loss of weight, because of poor nutrition, and on top of that, you say there might be other reasons. And I think apart from being at risk of cardiovascular diseases, I think there might be something underlying. So, severe hypoglycemia is a time to reassess the clinical needs as well as, and the underlying conditions, particularly with slow onset of CKD, because still a lot of people are not actually being assessed for the kidney function on a regular basis. And maybe that's the first time they have the kidney disease detected.
Thank you very much, Juliana, for raising this. We actually duly mentioned your important registry data in both of our publications, Excel and also TACOS. And, this is in our hands when we did this Charles and Comorbidity Index, which to a large extent also takes into account coexisting cancer, also leukemias. So if you look at the individual things, those are really very severely disabled people, like you pointed out. And it's interesting, the DEVOTE study, another cardiovascular outcome trial, they published all the individual causes of death in their publication. And you guess 40% had either cancer or other very severe chronic liver disease, and cardiovascular events were really minimal. Also in the DEVOTE study, which is of course evidence that the cardiovascular aspects are safe for the insulins tested in there. But like you pointed out, severe hypo, and we felt it might be reasonable. It's so simple to do this comorbidity index. And if you go to the list, there are 12 items. You clearly find all the cancer, and of course, this needs not only reassessment but also really to address what are the comorbidities, what needs to be done, and something actually where more minimize, perhaps also the potential for severe hypos, but at the same time, you reconsider what is the best glucose lowering therapy in those. And of course, they have a limited prognosis. So this is really medical art where you come to a good solution. But thank you very much for raising your important registry data, Julia.
If I can add, in DECLARE, surprisingly, we were mainly looking at major cardiovascular, major hypoglycemia, and we have quite a few of that, mainly when we look at it very deeply to make sure that this is indeed a major hypoglycemia. And altogether, we have very few, and I'm not even sure that we will show a clear relationship between that and cardiovascular outcome. We will soon publish it, so I don't want to go into it. But as I mentioned, very few, and it might be because our patient had a much better renal function. It might be because 60% of our patients didn't have established cardiovascular disease. However, also when we look at old age, this situation was relatively safe. And with dapagliflozin, as we already published, there was a reduction of 30% in the risk for major hypoglycemia, both in the old population and in the rest of the population. So somehow it looks not as bad as it looks in the other studies. Yep. And we're trying to understand why, and soon we will publish it. But no question that today we have to change the way we treat patients. We have to aim at drugs that do not cause hypoglycemia if possible, and use those drugs that cause hypoglycemia also as a last choice. Only as a last choice, sorry.
Okay. Thank you very much, Itamar. Of course, dapagliflozin is a very safe drug in terms of hypoglycemia, first of all. Can you tell me, probably I've looked at that, how many on the patient in DECLARE were on insulin therapy at baseline?
I didn't hear you well. How many?
How many were insulin users?
Right. We had less than you had at less than there was in EMPA. We had about 40% of the patient on insulin, and around the same percentage on sulfonylurea. So we're not very different from the rest of the other cardiovascular outcomes.
Okay. Thank you.
So, Dr. Raj, my question to you that why there is a sudden decline in the initial stages of using of SGLT2 inhibitors? What is the mechanism behind it, and how in the coming few weeks it improves the eGFR? What is the mechanism of SGLT2 behind improving?
Well, the mechanism is debatable, but for one thing for sure, this drug tremendously reduced the intraglomerular pressure. And that's why at the acute phase of treatment, you see a large reduction of eGFR. It was a reduction of 6 millimeter per half a year in eGFR in those treated with DAPA versus around 2.3 in those treated with placebo. So most probably this is the main reason why this drug protects the kidney through the tubuloglomerular effect. And there are many other different mechanisms that might be suggested, like reduction in uric acid, reduction in blood pressure per se, and many other yet really proven.
Thank you.
Itamar, can I ask something, Ebehard here? This first decline in GFR, in all likelihood, is a functional thing. because if you do a cessation of the drug for a few days or so, it really goes up again. Whereas the long-term benefit is probably a structural benefit. This would be my concept in that. Are there any data underlining this, one part functional, the other one structural changes?
Well, Eberhard, it's truly functional. I mean, it's truly functional. We don't have yet a very accurate subgroup analysis to see the difference in each of those groups, but no question that it's functional. And we do know that in most of the cases, there is a decrease and then it goes back to what it was within a year. We didn't see it in our study. I mean, in most of the studies in the EMPA and others, you do see a reduction, and within half a year to 1 year, it goes to the same baseline EGFR, which we didn't show. So this is most probably functional, but there is no question that after a short time of functional effect, you start to see the long-term effect, and there is no question about the long-term effect. The reason that I wanted to do the fast progressor was that I really wanted to try and see who will be the patient who will highly benefit from this drug, even if they receive it when their EGFR is 80. And that's what we try to see now, when we can characterize, have kind of a score that will let us know who are the patients that will benefit from this drug. It's also important at the other side. If you take a patient with EGFR 35, these drugs are not considered for that yet. But if you take this patient and you ask yourself, should I add a drug or not add a drug? If a patient has EGFR of around 35 for the last 5 years, it might be more deleterious for him than beneficial for him. If on the other hand, he was 45, 50 several years ago, now he's 35, this drug can make the whole difference from going to dialysis. And that's why we did this study, and we'll come with further analysis very soon.
So on that point, Itamar, so did you actually compare the baseline characteristics between those who are fast progressors and those who did not actually have decline? For example, in terms of A1C, age, baseline?
No, Juliana, this is a perfect question. We are doing now a mediation analysis.
Okay.
At the beginning, we wanted to do it only for A1C, only for microalbumin, only for hematocrit, but we decided to try and do a mediation analysis of all the variables that might be important in kidney deterioration or in cardiovascular deterioration. So this is a very complicated thing to do. It takes us a lot of time, but we'll hope to come with a paper about a mediation analysis of all the risk factors, some of which you already mentioned.
Well, but as it looked, baseline macroalbuminuria seemed to be a situation for people who benefited the most at the end of the study. In your slides,
Right.
Just sometimes I think that communicating that information to our patients is quite important, because if somebody actually is losing, for example, like 6 ml per minute per year, in 10 years' time, they lose 60% of their kidney function. And I think a lot of patients don't understand that kind of significance. But when you tell them actually you start with 100 and then 15 is your end-stage renal disease when you need dialysis, you only really not 85 mils to play with. And if you're now losing a 4 mil or 5 mil, 10 years is already 50% gone. And I think suddenly,
Right.
I found that these patients suddenly they say, because it's quite different from cardiovascular disease or stroke or ischemic heart disease, they have no symptoms, they have symptoms. But really that silent deterioration in GFR is, is very, very, insidious. And you have people who come in, repeat the medications, still obese, still smoking, and the blood pressure not so well controlled. And then 20 years time, suddenly the EGFR is 15, and they might still be in their 50s. I see a lot of these patients in my clinic, and it's actually quite frightening. Yeah.
You are true, Juliana. We also see these kinds of patients. So
I think obesity and smoking are two very important factors.
Right.
Particularly, for example, in our clinic, Many of them are already, I would say 90% of them are already on RAS inhibitors. They're already on statin. Their A1C is not really that bad, right? You see, but many of them are persistently smoking. Many of them are very obese, right? And the other thing is the uric acid may also be something quite interesting. As eGFR continue to deteriorate, I think the uric acid would go up, and I think that might reach a threshold when it actually start causing, renal impairment. I think those are probably unmet needs in, when we manage people with CKD.
Right, just recently they published a paper showing that bariatric surgery can prevent renal deterioration. And I remember myself several times suggesting that to my patient. The problem is that very obese patients many times have a severe heart with tendency to renal failure, have also cardiovascular disease and all the others, and they are very, they are worried to go through bariatric surgery. But I think this can make a huge difference in the health of those patients. And I believe studies will come to show that.
Dr.
Thank you
Stan,
very much. Thanks a lot to all for the excellent topics, and you have covered it very well. Thank you, Dr. Juliana. Thank you, Dr. Raz and Dr. Stan, for your nice deliberation. Thank you, Dr. Shah. And Jimit, over to you.
Thank you so much, chairpersons, for conducting this wonderful session. Thank you all the international speakers. We had a great time with you. We have learned so much here. And we wish to see you again in India as soon as the lockdown gets over. Thank you so much. Thank you.
Thank you.
Thank
you,
you.
Bansi sir.
Thank you.
for this
Bye-bye.
opportunity.
Thank
Bye-bye.
you. Thank you, Ichima. Thank you,
Bye-bye.
Dr.
Greetings to Israel.